Today I'll be talking about ballistic resistance training and its effect on mobility for people with traumatic brain injury, and a randomised controlled trial that we have recently completed and published. There's a lot of work went into the development and design of this RCT, so I'll just briefly cover the background. So we've been interested in the impairments that contribute to mobility limitations after traumatic brain injury, and how people recover over time, given we see some very severe and complex movement disorders, and how people recover over a period of time, and what are the key features associated with that recovery that we need to target in our therapy. When we look at the common physical impairments that impact mobility, there's some research to suggest that balance contributes to mobility limitations, as does spasticity, contracture, motor control or motor skill. But in traumatic brain injury and other neurological conditions like a stroke or cerebral palsy or MS, it's becoming increasingly apparent that muscle weakness is the key impairment that limits mobility. We did a review 10 years ago now, looking at resistance training for people with neurological conditions that had trouble walking. And in this review, we looked at 25 different RCTs that had done strength training to improve mobility. And what we found was that that these studies were not including the key muscle groups that contribute to forward propulsion for walking. So those are the muscle groups highlighted in green there, so calf raises, hip extension and hip flexion. And so the key muscle groups had not been targeted, which is problematic. So what we set about doing was looking at task-specific resistance training, okay? And the parameters for what task-specific actually means are outlined in the American College of Sports Medicine guidelines for resistance training. So they talk about things like the role of the muscle, the action of the muscle, the type of contraction, the active range that the muscle works through in the segmental alignment, the load, and critically, the speed of movement. And so really what we're trying to do is replicate how the muscles work in the exercises which we prescribe. And so it's been well established, for decades, what the key muscle groups are. So that from that graph highlighted in green previously, the key muscle group for walking is the ankle plantar flexors that contribute over 60% of all the work done for forward propulsion, followed by the hip flexors and hip extensors. And so previous work had largely focused on the knee muscle groups for power generation or strength, and really the role of the knee during mobility is to absorb power rather than generate power. So the aim of this RCT was to determine whether a 3-month ballistic training program targeting 3 lower limb muscle groups was more effective than usual care for people with mobility limitations, and did any improvements translate into better health-related quality of life. The inclusion criteria was that they had to have a mobility limitation as a result of a brain injury. They have to be out of that post-traumatic phase, aged 15 to 65, in the subacute recovery phase, so less than 12 months. They had to be able to be full weight bearing, because some of our participants had fractures in their accident, and be able to walk without assistance of a gait aid or therapist for 10 metres. And they had to score below 50 for males and 44 for females, so that they wouldn't hit the ceiling of the high mat, which is our primary outcome measure. So this was a prospective multi-centre randomised controlled trial with concealed allocation, intention to treat, analysis and blinded measurement, everything you'd expect in the CONSORT guidelines. The protocol was registered and published. Participants obviously had to have a movement disorder. The primary outcome measure was the high mat, which is the high-level mobility assessment tool. So this covers a range of mobility, and that is because many of our younger patients with brain injury have goals that are higher level than just walking and walking speed, which is the most commonly used outcome measure. This was conducted at 5 large brain injury rehab centres around Australia, so 2 in Sydney, 2 in Melbourne, and one in Adelaide. The high mat was chosen because of its strong psychometric properties and chosen because of a capacity to quantify high-level mobility. The secondary outcome measures were strength, balance, walking speed, and quality of life. In terms of the intervention, both groups did task practice, so walking outside, crossing roads, over, up and down gutters, things like that. And in relation to the intervention group, they were basically doing task-specific ballistic training, so fast resistance training. And we're trying to teach the muscles to contract more quickly under load. And both groups had built-in progression rules, but the control group did usual care, which included strength, stretching, static and dynamic balance stuff, cardiorespiratory fitness training, and they also did strength training, but they did it what we would call more conventionally, and as you'd see in other RCTs, so slower and heavier rather than task specific. 144 people were randomised, 131 completed the intervention phase, 114 completed the 3-month follow-up. Our groups are well matched at baseline with no between group differences. We had good compliance and fidelity with the protocol at all sites, and all RAs were monitored. Both groups did an average of 31 out of the 36 sessions, so this was done 3 times a week for 12 weeks. So there's no difference between groups, and each group spent a similar amount of time in each session exercising. There were 2 minor adverse events, which were both non-injurious falls, which occurred during the assessment. So what we found was after 3 months that there was that the experimental group scored 3 points higher on the high mat than the control group, and they remained 3 points higher at 6-month follow-up. So the improvements they made were maintained. There were no significant between group difference for any of the other secondary outcome measures, except for this transitory improvement in balance at the 3-month mark, which was not there at the 6-month time point. What was really interesting to see was that for those who were more impaired with their balance at baseline, they had an extra 6-point improvement on the high mat compared to those who were scoring higher than 27 points on the high mat at baseline. So the key points here were that replacing 3 sessions a week of the usual care with ballistic resistance training resulted in better mobility. Those with more severe mobility limitations at baseline had even greater improvements. As expected, both groups made significant improvements because they were in the subacute rehab phase, and there were no other between group differences other than that transitory difference in balance. And they did improve despite the severity of their brain injury and their concurrent fractures that had healed. Neither group did high-level mobility training, and so the point here is that they all did mobility training. They all practiced walking outdoors and over obstacles and crossing roads, but no one did high-level training. So no one did any running or advanced mobility training that might be appropriate for people who are starting to walk faster. The strengths were that it was fully powered, the groups were similar to baseline, they followed the consort guidelines and the TIDIA guidelines. So the TIDIA guidelines outline how you should report an intervention so that anyone reading it can then pick it up and do it themselves. They can understand what was actually done. And we were able to complete this trial despite significant COVID disruption. The weaknesses were obviously that we're unable to blind participants. We had 9% loss at 3 months and 20% loss to follow up at 6 months. But over half the dropouts were due to moving back to a regional centre. So in all 5 cases, these large brain injury units often commence someone's rehab once they were medically stable, and then people might move back to their regional centre. And so we over half the people that dropped out, were moving back home. Another quarter were due to COVID disruptions. So ultimately, we had very good engagement and adherence from participants. So to conclude, this randomized controlled trial suggests that ballistic training has an additional effect on mobility for people with traumatic brain injury, and it may be better targeted towards those with more severe mobility limitations. These were the two papers, the protocol that was published in the Journal of Physio and the resulting RCT. Thank you.